Hello, everyone. Good afternoon from Vienna, and good morning or good evening for those joining from different locations. Welcome to the today webinar on radiation protection in medical uses of ionizing radiation, organized by the Radiation Protection of Patients Unit of the International Atomic Energy Agency, this time jointly with the International Organization for Medical Physics. I'm Jenia Vassileva, Radiation Protection Specialist with the Radiation Protection of Patients Unit of the IAEA, and I'll be your moderator today. The webinar will last approximately 60 minutes, including a specific question and answer period at the end of the lecture. The microphones and cameras of participants are disabled during the entire session, and questions could be submitted by writing using the Q&A box located on the right-hand side of your screen if you are using a personal computer, or in a specific box of your mobile device, depending on the different type of device you are using. We welcome your active participation, look forward for your questions, and please note that the IAEA is not offering certification for its webinars, just answering some of the questions already received before we started. The webinar today is, I mentioned, is organized jointly with the IOMP, and it's on a current hot topic in radiation protection of patients related to the recurrent computed tomography imaging, managing cumulative doses and strategies to improve radiation protection of patients undergoing recurrent imaging procedures. The topic attracted attention during the last few years with the improved access to computed tomography and other imaging modalities, resulting in a growing number of imaging procedures. Furthermore, with the improved access to automatic radiation exposure monitoring systems, the access to data about the imaging history of individual patients has improved, allowing for analysis and conclusions that have not been possible in the past. Today, we'll learn the data available to date from one of the most active researchers on this topic and a renowned expert in radiation protection in medicine, Dr. Madan Rehani, who is currently also the president of the IOMP. Dr. Rehani is the director of Global Outreach for Radiation Protection at the Massachusetts General Hospital in Boston. He was previously a radiation protection safety specialist at the International Atomic Energy Agency for 11 years, and previously a professor and head of medical physics at the All India Institute of Medical Sciences in New Delhi, India. Dr. Rehani is a member of the International Commission on Radiological Protection. He is a co-author of 8 annals of the ICRP, 4 of which he served as chair of the task group. He is senior editor at the British Journal of Radiology and associate editor of Medical Physics, and he has published more than 160 papers and 39 books, chapters, and has edited 5 books. And related to the topic of the today meeting, Dr. Rehani chaired the IAEA technical meetings in 2019 and 2020 on recurrent imaging. So we are ready to proceed with the topic, but before I give you floor, Madan, for presenting the topic itself, could you please clarify what we mean under recurrent imaging and what is the difference between the recurrent imaging and multiple or repeated imaging?
Thank you, Jenia, and through you to the IAEA for this collaboration with IOMP. I am honored to speak on this topic today. And I want to thank the participants who are there in large number. Thank you. And I wish you a learning experience. Going by the question which was posed by Jenia a minute ago, let me say that this webinar is going to be interactive. We are going to have polls run so as to have your feedback, and between Xenia and me, we will shuttle to have a better understanding of the many situations. So coming back to the question of recurrent exposure, historically, if one looks back in 1980s, we used to talk about retake rate, repeat rate, reject rate. So that was very common. And that concept was based on the image quality. When there are poor quality images or non-diagnostic images are there. So we used to use that concept there. And it was more common in radiography than with CT, because the CT was something which was very expensive at that time. And the dose was also high. And the time needed for CT was also reasonably high at that time. So it was in 2000s or late 1990s that spiral CT came up and the multi-detector CT came up, which was faster and faster. And then the recurrent CTs became something more common, and with time it has been becoming common and common. So this is different from the concept of multiple imaging or retakes, which was from the point of view of quality, whereas recurrent imaging is for the same patient for diagnostic need. I should take this opportunity to say that CT is one of the best imaging modalities available in the medical sciences. Its uses, its efficacy has been really, really great. And it is the success of the use of CT that results in sometime situations with risks. And that is what we are talking. But the utility of CT is really unquestionable. So I think I will, as I said, we will shuttle between myself and Xenia to ask each other, and that will create interaction at our level. And then we will interact with the audience also. So let me ask Xenia a question to you, that there has been a lot of use of the collective dose in the past. It has been used by IAEA, by UNSCARE, by various European Commission, various organizations. So what value that adds in recurrent imaging, if at all, anything?
Thank you, Madan. I also think that's important to clarify the difference between collective dose and cumulative dose we are talking today on. So collective dose we use for analysis at population level. We can assess collective dose for a country, for a region, or globally. And the global estimate is normally made by the United Nations Scientific Committee of Atomic Radiation, UNSCARE. So population dose or collective dose we calculate by summing the number of exams by typical effective dose per exam. And this enables a follow-up of trends, make comparisons between examinations and between countries, identify the relative importance of specific procedure to the overall population dose. And as an example, I added here two graphs from the UNSCARE analysis reports. On the left side, the pie chart on population dose, the contribution of different imaging modalities to the population dose. That's based on this analysis. And on the right side, the trends in the collective dose over the time. This is from the latest available report. We are expecting a new report very soon. This helps prioritize efforts and resources in radiation protection. Today, we are talking about cumulative dose. So we stay in the discussion at the level of an individual patient. Patients are different in age, sex, and many other conditions. And we talk about the exposure history of the same patient over the time. I hope I answered your question. And to continue, let's ask you, Madan, on how really cumulative dose is needed. Isn't it enough to have history in just the type of exams, number of exams, and make this available for the taking decision? How the cumulative dose adds to this decision?
Thank you, Jenia. It was only a few weeks ago that our emergency physician in Mass General Hospital sent us the list of 148 patients. And these are all the patients who came to the emergency with severe diffuse abdominal pain, fever, tachycardia. So with the question of diverticulitis. So he asked us if we can provide him information about the radiation doses received by these patients. And when we looked at the DLP values, they varied from 186 to 3,488. So it was 18 times. So you can imagine that when it is the same hospital, same setting, same type of patient, and same type of exam, abdomen pelvic CT, 18-time variation in the dose. Even if one looks at the median value, which is 817, compared with the 186, it is almost 5 times there. So it's a lot of variation when one looks at the dose as compared to the procedures. So that way, procedures alone may not be a good way to look at the situation, and we do need to look at the dose. So let us now look at the other possibility, how to look at the dose. For example, when we are talking of recurrent imaging, it may involve chest, abdomen, pelvic, and sometimes head also. And if one looks at the table of any CT exam, this was of course for pediatric, but there are similar tables for adults, the brain, pituitary gland, lens, eyeball, so all that. So with the abdomen pelvic scan, there are so many organs which are irradiated, and there is a dose associated with each organ. So this is something, if we really should go by that, and let us have a poll from you people. So let us check up with you. Do you have experience in assessing organ doses in situation of recurrent imaging? I think on the right side, you will have a poll starting. So I'm sure you will be able to see on the right side. I can see it there coming. So let us have your response on that in a few seconds. The question is, do you have experience in assessing organ doses in situation of recurrent imaging? It is not in one imaging, but recurrent imaging. It is chest, abdomen, pelvic, head, so there's different body parts. So this poll is anonymous, so we will have the percentage values of the response for each. So don't worry about identification. There is no identification.
Yeah, there are a few more questions coming, waiting.
Yeah, we will see. Okay, I think we should be able to stop this, or you want to?
Yeah, I can stop, but there are more answers coming.
Okay. Yeah, we have 750 people, so obviously it takes time.
Yeah, most of people already replied, so maybe I'll close the
Yeah,
poll
you
now.
can stop now and let's go. I don't see the answer.
Just a second. Two seconds. Okay.
Not yet.
Do you see that?
No.
No?
No.
Okay, sorry.
Yeah, now.
Okay, yeah, it was mine.
So 19% yes, 52% no, and no answer by 30%. So let's go to second question now. So do you have experience in using organ doses? Some people said that they have experience. So let us say 19 people. So where have they used it? If you have experience of, if I go to my physician, so let me first have the answer and then I will say. Do you have experience of using organ doses estimated from recurrent imaging? So we have now 765 people.
Yeah, majority replied already.
Okay, so you can stop.
Okay, let me close the poll.
So this is same as like no is more 51%, yes is 14%, so others did not reply. So it's very small fraction. So that is where the situation lies, that we don't know how to use these doses. If I talk to my physician and tell him that the organ A has got this much, organ B has got this much, organ C has got this much, organ D has got this much, and it creates a confusing situation. So it's really something which has not been practicable so far. So it really leads to confusion, and that is where the only option at the moment is effective dose. And when it is multiple exams, then cumulative effective dose. So even ICRP has accepted that, and this is the paper which we had published from the ICRP side, and ICRP publication 147 is on its way. It should become available soon. They have not yet announced it, but it is almost ready. So there also they have accepted that cumulative effective dose is good in such situation in which we are talking. So let's have another poll now. So we have a series of polls for you people. Do you think your patient, it is not from the literature information, that may be getting radiation dose over 100 millisievert through CT exams? So we will have a separate poll for literature information. This is from your patients. If you're not involved, then you don't need to answer this question. Go ahead.
Yes, we have 60% already replied, so maybe we can close the poll.
Yeah. Half of 29% remaining, 42% no answer. So yeah, that was what is anticipated. Next one. If yes, then if yes for patients getting 100 millisievert plus through CT, what fraction do you think is the correct? 1 in 100,000 patients getting more than 100 millisievert through recurrent CT exams, 1 in 10,000, 1 in 1,000, 1 in 100. Okay.
Yeah, let's wait just maybe a minute more. Okay, I think
Yeah.
We can close now. You can see the results.
5%, 13%, 13%, 9%, 60% no answer. So yeah, most of the people obviously may not be knowing, so very few, and then scattered over all the 4 situations. Okay, so still one more question. Do you have some automatic dose monitoring system in your hospital like these? So there are.
It could be also housemate.
Yeah, anything. Because this answer to these questions which we have can rightly come when there is some dose monitoring system in place rather than being able to do manually. Because the numbers are really large in terms of the numbers of patients undergoing exams. So one has to have some kind of a automatic system.
Okay,
Right.
close now.
Right. 42% no answer, and then 33% yes. So 254 out of 778. So that's a good number. So yeah, that gives us a fairly good idea of how the situation is among the participants of this webinar. So if 250 people have access to, that's really good. So it means one can think of really good data to come in the coming year. So that is what we wanted to know. It's very nice. And one more question, have you come across literature now, literature reports indicating roughly 1% patients undergoing CT having cumulative effective dose of more than 100 millisievert, equal to or more than? Okay.
Okay, I'll close this poll now.
46% no answer, then remaining 16 and 38% no, 16 yes. Have you come across? So 16%. So that way this seminar and this webinar is of use because most of the people have not come across. So that will show the utility of this webinar. Okay, Jenia, I come back to you. The dose management system has been in use in many countries in Europe. Do you think the cumulative effective dose has been used to refuse a needed CT examination?
In fact, we haven't studied this, so I will answer just on the experience from different meetings I organized. And what you can see now is that one of the results of the survey we organized in the preparation of the technical meeting in 2019, from which we see that those monitoring systems were widely available in 61% and of those who responded, and most of them came from European countries. Although these systems are not mandatory yet, they are not required by regulation, they are widely used and more used nowadays. To best of my knowledge, there was not such case. At least I haven't been communicated. We haven't received such a comment that having access to cumulative dose was the reason for a physician, either referring or radiologist, to refuse an exam. Of course, this doesn't mean that this information was not used by the physicians, by the radiologist, to probably modify the decision, but not to refuse an exam, at least to my best knowledge. Madan, back to you.
Okay, so
yeah, maybe it's a logical question, what should be done to avoid misuse, because that is the main concern. If we have access to cumulative effective dose, how it should be properly used, because there are no dose limits for patients, and we should guarantee that this information is not used as a limit.
all right, I'm sure all of us teach people that radiation is not as harmful as fear of radiation is. All of us, I'm sure, present in this webinar 799, I see now, I'm sure every one of us is convinced that radiation is not as harmful as the fear of radiation. So it is always the fear. But the problem is when we teach this thing to others, but we ourselves are affected by fear. For example, take the example of vaccine today. When anything new comes up, apprehensions are likely. But after some time of its use, the data should talk rather than the fear. So we have to see whether we are guided by the fear or by evidence. We had debated this point in the point and counterpoint, which we published in Medical Physics in February 2020, and I will direct people to see this publication. So let me, to answer this question, take the example of something different. It may look something strange here, but this has a very strong message. For example, it was about 10 years ago that papers like this were appearing in literature. Brain tumor among interventional cardiologists, a cause for alarm, report of 4 new cases. Another paper, brain cancer in interventional cardiologists and physicians, is occupational radiation exposure the cause. Another paper summarizing the reports from Toronto, from Israel, from Paris, from Sweden and all that. Various case reports with kind of tumors observed in that. So when these all reports were appearing, obviously it will lead to fear. So that is very natural to happen. And see further more reports. So if one can survey these reports, there were quite a few reports between 2010 and 2013 or 14. So it was that time that NIH took this study and published in Radiology, in which they surveyed data of 30 years. They took more than 45,000 physicians who were performing fluoroscopy guided procedures. This was the distribution of those, and compared the results with more than 64,000 psychiatrists who have no reason to be using fluoroscopy. So that is a fairly large study, and the conclusion from there was that they did not find elevated cancer deaths from the cancers in MDs performing fluoroscopy guided intervention as compared to psychiatrists. So that is where we need to learn from. For example, these case reports, they were published, they were in scientific journal. People can say that this is science. Then comes a controlled study, large study, which is also science. So it's a question of how we look at the science. We are looking at the case reports, or we are looking at the large scale studies. So when we talk about misuse of the cumulative effective dose, we need evidence. So this second bullet point shows evidence. The first bullet point was some case reports. So the former will lead to fear, whereas the later will lead to the comforting feeling, as the previous slides have shown. So I think we as scientists need to be guided by evidence rather than apprehension or fear. Cumulative dose is not something which is started today. It has been there for 2 decades at least, actively for the last 1 decade. And in the beginning, apprehensions are likely and they are fine. But now we need evidence. If we don't, add to my knowledge also, I have not seen even a single paper. Jenia also mentioned same. And if anyone in the audience has seen paper, please let us know by email and we'll be very happy or today. And but even if one or two cases are there, if they are there, so one needs studies on that. So we need evidence to say that. So the cumulative dose is it the fear of misuse, which is really creating the issue, or the evidence? When there is no evidence, there should not be fear unnecessary. On the other hand, we have tons of benefits on patient safety. This is going to guide the directions for patient safety. This is one paper I will strongly recommend people going through it. This is written in the form of a novel, so that it is very, very easy to read, in which we have dealt with the situation of how to deal with a cumulative dose, how to get better in terms of justification of the procedure using the cumulative dose. We have taken the analogy of the drugs, the pharmacological drugs, where there is a risk-based system rather than the dose-based system. So we have a dose-based system rather than the risk-based. We need to have stratification of different risks. Like in medicine, the more the drug dose is given, depending upon the risk. So FDA says that you can use a drug in much higher doses where the risk is more and the benefit is likely to be more. So now we come to the actual papers which have quantified the number of patients, because the poll showed very few people knew these, so it may be educative. See, the paper on cumulative dose from recurrent exams have been there for the last, at least from 2009, when the Aaron Sodixon's paper, and after that there have been large number of papers. So the difference between those papers and the new paper is that these are sort of population based. One knows from how many patients who are undergoing CT exam and how many % of them are going to have higher dose. So that kind of information was hardly possible from the previous papers. The previous papers were telling about how many % of the patients in A particular disease or B particular disease or C particular disease are likely to have, but they were difficulty in having the population statistics. So this is the large study in which was published in April 2020 in European Radiology. This is data from hospital where I work for the 5 years. We had 19 CT scanners and 0.26 million patients undergoing CT. Another hospital, 2 years, 7 months data. So total we had 2.5 million patients who really were there. So this was almost 324 hospitals involving. So 2.5 million and 3. So we had almost 3.4% of our patients getting cumulative effective dose of 100 millisievert or more. So 100 millisievert is not to be seen as a threshold for radiation effects. It is just because at 100 millisievert, many organs are having more than 100 milligray, which is a reasonably high dose for potential radiation risks, where it is not easy to ignore that. So there is no other basis for choosing 100 millisievert. So it should not be seen as a threshold for radiation effects. So other hospitals, 1.4, 1.5%, 0.64%. If we take the overall average value, 1.33%. So we had a question few minutes before. So how many? So it becomes one in practically 1 out of every 100 patients. So roughly 1 out of every 100 patient who undergoes CT scan is having this. So this is overall. There were cases in hospital where there was 0 case of 100 millisievert. There was cases, it was maybe 0.1%, 0.2%. So average, because this was a large scale study, this was an average. So if one undertakes this work in individual hospital, there may be hospital which may be having less than 0.64%. Recently, there is a paper 2 days ago from ESA studies. They have taken the average. They have found the average value of 0.5%. So that is roughly the range. So only from recurrent CT exam, it does not involve the nuclear medicine exam that these patients may have got. That doesn't involve the interventional procedure. So we have estimated from there almost nearly 1 million patients are likely getting added every year globally with cumulative effective dose only from the CT scans. So we had done estimations for 35 countries in the OECD regions. And we found that the number of patients likely getting more than 100 millisievert in 5 years is around 2.5 million patients from 35 OECD countries. So such estimates were not possible with the previous publications because, as I said, they were not population based. They were not based on the fraction of the patients undergoing CT exam in any hospital, a typical hospital setting. So these 35 countries, the further details are available there. So let me come back to you, Jenia. What about data collected by IAEA from some countries on this issue? You are muted.
Thank you, Madan. As I mentioned, these data were collected during preparation for the technical meeting in 2019, and the results are published in the paper already shown by Marco Brambilla in European Radiology. And in this survey, we collected data from 20 hospitals, 18 of which in Europe, 1 in Africa, 1 in Asia. The issue with having data from all regions is the access to radiation dose monitoring systems, because this was, of course, the main source of data, automatic exposure monitoring systems available in these hospitals. The big variation was found in the numbers, first because of the difference in practice, but also the period of data collection was different. The access to data was from 0.4 to 6.1 years. But we also found, despite these variations, from 0% patients with cumulative effective dose about 100 millisievert to 5% in one of the hospitals in Europe, in only 1.8 years. But the average percentage was 0.65, in fact, conforming or similar to the results of the previous study published by you. So there are not much data coming from less developed countries, and we hope with the wider use, easier access to the automatic exposure monitoring systems that are not cheap nowadays, we'll have better estimate. We definitely need more studies on this. In the second meeting we organized in October 2020, last year, we also invited participants to present their own data, and this slide shows data from France. They are published in the annual report of the French Radiation Protection Institute online, available online. And you can see also, depending on the years of accumulation, this percentage increase, but it's also from 0.49 if 1 year accumulation is in place, up to 2.25% for a 6 years period. And also another data were presented from the big hospital in Belgium. In fact, this is not from one hospital only, from Professor Hilde Bosmans, from 23 Belgian hospitals, also confirming this percentage from another hospital in Italy with only 1 year data collection, and again 0.29% fall, up to 0.65 for a longer period. And also data from Bulgaria, from 3 hospitals, depending on the profile of the hospital. Highest percentage in hospital with oncology profile, 1.9% in cardiac, and 2.3% for multi-profile hospital. And this is for 3 years of data collection. So yes, variations exist, but all these data coming now and more publications are coming show that the estimate we made at a global level could be probably relevant. So back to you, Madan, asking maybe, because of course we know that mostly oncology patients undergo recurrent exams, but are they only oncology patients, and what age these patients are? Are they in older age bracket only, or they are younger also? And also, what about overutilization of CT, because this accounts for overuse of CT, and also what about optimization aspects? Can we improve this cumulative doses with proper optimization?
Thank you, Jenia. So it's a very common thing to find that people make assumptions, and there is no exception here also, that people think that most of the patients who have been having these high doses, they must be having malignant disease, chronic disease, high age bracket of more than 50 years, and the overuse must be there. Appropriateness criteria may not have been used. So we studied everything. For example, this is the data from that large study of 2.5 million. We found that nearly 20% of the patients were below 50 years of age. So practically 1 in every 5 patients is below 50 years of age. The range was 13.4 to 28% in different centers. And then we also studied the optimization aspect. For example, in US, there is ACR, the American College of Radiology Dose Index Registry. Every week they update, every month we get values of all the participating center for different exams with or without contrast. So these are the values taken at a particular time. And like our hospital, the values are all lower than that. So that with optimization becomes clear that our values are 75% in this, 89, 84, this, and here only 38% of the national benchmark. So 1/3 of the value for CT angio. For other hospitals, of course, in some they were higher. So at least there is a way now to find out if the optimization is good or not good. So do we really know that what had caused this recurrent imaging? Could it be that there was no inappropriate imaging? There was no unoptimized imaging. So these questions were never posed before. In the earlier time, whenever there was any paper with increased doses, straight the blame used to go on overuse and unoptimized use. So that was the way to deal with the high patient doses. But we are now in a totally different situation. For example, let us dream of the situation that all the imaging is justified and optimized. So is it possible to have that situation? Let us see that situation. So will it solve the problem? For example, the ACR has appropriateness criteria, and many other countries also have, many other regions also have. It doesn't mean that others don't have. So based on that appropriateness criteria, clinical decision support system is created, which will tell based on the conditions of the patient, symptoms of the patient, if the rating is 7, 8, 9, green, 4, 5, 6, yellow, 1, 2, 3, in the red range. So that gives the appropriateness. So we did the appropriateness studies in our hospital, and we found, we focused only on patients who were below 40 years of age and with no malignancy. And we found the number of times these factors were leading to the multiple CT scan. Also, we had done review by the clinicians since this was the chest CT we took, so we took the pulmonary physician and cardiac pulmonary physician. So they analyzed each and every CT scan done in the limited study, comparing it with the clinical society guideline of pulmonology and cardiology, and they found that large fraction, 87 to 100% were appropriate. So this is so more than half of the CT exams were unrelated to follow-up of the primary chronic disease. So that also dispels the feeling that, oh, all the imaging is done for that particular disease. It is not the case. So with that in background, we have seen this in the previous slide, and let us go further. So we have at our hospital the clinical decision support in place. The optimization is there. Still, our values were highest as compared to others. So that shows that when the CDS is there since 2004, it is being implemented. It is regular updates are done from time to time. We are world leader in this field of using clinical decision support in radiology. And so we have lower doses than the national benchmark. So it means both the best possible justification system is in place, the best possible optimization is placed, although there are always possibility to do better. But this is what one can imagine. And despite that, if we have highest value, percentage of patients with more than 100 millisievert, that means that the patients with high doses are a reality, and they can happen. They are happening a lot. One fact and one myth I want to dispel is every time I find our colleagues saying, oh, these patients are having malignancy. So 80 to 90% of the patients who undergo recurrent, this is fact that 80 to 90% of these patients in our study also had malignant disease. And but this is a myth, that why should we be concerned about radiation risk? So that is where the myth is. The fact is, cancer patients are given radiation only to the tumor, not to the rest of the body. For rest of the body, the person needs to be treated the same way as like any other person. So this is just a fact to be. So I think that this is the last poll. Let us quickly go. We are running short of time. Is it possible to for patients to get more than 100 millisievert in a single day? We have 809 people present. So all right. Okay. You are muted.
Almost 60% submitted their answers, so I'll stop the poll now.
Right.
You can
So 42% did not attempt. So 36% said yes. Oh, that's interesting. 21% no. Yes. Yeah. So this is the paper which was published a couple of weeks, maybe 2 weeks ago, 8 March. So it's only 1 week ago. in which we have focused only on single-day radiation dose. And we had 4.3 million CT exams in these patients performed in about 3.8 million patient days. 0.8% received more than 50 millisievert in single day. 0.03% had received 100 millisievert in a single day. So 9.4 underwent more than one CT exam in a single day. Nearly 1/3 dose of 50 millisievert were in less than 50 years of age. So we identified 20 top exams which led to more than 50 millisievert in a single day, and all belong to chest abdomen. So these are the exams, and this is the frequency. You can look in the papers. We had published this paper almost 9 years ago from Finland, the experience, and the conclusion was that patient-specific justification and dose optimization is possible using tracking of the radiological procedures and cumulative dose. So the experience from the tracking at some centers who have been doing for almost a decade, it shows that strengthening the process of justification by avoiding another exam, strengthening the process of optimization, information for audit purpose and quality. So this has been helpful. So what is the future of optimization? There is a possibility of optimization based on individual patient rather than like the DRL is based on the group of patients. So this will lead to optimization based on individual patient, doses for indication-based examination and suggested changes. So whole new era of optimization, which will be departure from DRL, which is likely to happen. So to summarize important points, what we need to know that patients with 100 millisievert are in millions. As we have said, this is possible when justification and optimization has been practiced. And perhaps this may be the first time when imaging appropriateness in such patients was seriously studied. And before I close, let me say that CT is a very useful technique. And what the purpose of this webinar is to work in direction of making patients safer, not to stop a needed examination. If there are 82 million CT exams today in US, we want double of them in 5 years because patients need them. So it is certainly not, the purpose is certainly not to cut down on the use. The purpose is to make patients safer. So this was, but this one should realize that we need actions to make patients safer. Thank you very much.
Thank you very much, Madan. It was very good overview of the topic on the publications published until now. There are really ongoing research studies on this topic, and we expect more to come in near future. Okay, we are receiving questions, so maybe we can try answer most of them. I will maybe ask one that is linked to what you just said on the optimization. When we speak of optimization in imaging, don't we have to first ensure that optimization is defined the same way for all institutions? That is, of course, a good goal, and we need standards for this. So maybe, Madan, you can also put your comment.
Yes, fully agree that for the last many years, any paper published will say our values are below the DRL, and that means optimization. So that is not the correct way. These days, more and more publications are showing how much percentage below the DRL. Of course, maintaining the image quality always is necessary, and we have published papers on integration of quality, image quality with those. So yeah, so one needs to have a better and better optimization and not just being below the DRL.
Okay, provocative question, maybe it's your comment will be very welcome. Most people will receive more than 100 millisieverts, 100 sieverts, not millisieverts, cumulative dose in their lifetime from background radiation. So do you know that cumulative effective dose is harmful?
This is outside the scope of this discussion, but quickly to say that background radiation, whatever we get, there is a process of adaptation and all. So there has been no documentation of increased cancer incidence among people who live in high background areas. So I think I won't say much on that, because let us focus more on patients, and the patient doses are the one which are of concern, and whatever best we can do to optimize the patient doses, that means getting the appropriate image quality at the lowest dose, that is the issue.
Yeah, but maybe also to add here that most of this data that we have shown, they're accumulated over a shorter period of time, not over the whole life.
Yeah, we have
2-3 years, 1 year, 1 day, 1 week, even.
Yeah.
So that's a different dose rate, in fact.
Yeah. So I think that is one of the next thing which we are now doing, to estimating in the 10 years, 15 and 20 years. So at the moment we have data only from maximum 5 years, and the other part can be either extrapolated and extrapolated, and models can be developed to find out how much will be the lifelong exposure of the patients.
And we expect more evidence and data from the radiobiologists and epidemiologists on this. I can refer the participants to the recording of the last technical meeting. There are very interesting presentations. At the closing, I'll show the link to the information on recurrent imaging of the IAEA website, where you can find a link to the recording, and there were very interesting presentations from what we know from the epidemiology and what we expect in future. Another question, can we assume the number of people with over 100 millisievert is higher than suspected for the moment, since patients can undergo CT, and not only CT, I could add here, not in one hospital, but in several hospitals. So who do not share those information? That is the question of having tracking not in only a single hospital, but ideally from all the examinations that the patient undergo. Madan, you may comment, because you've been the driver of the smart card project of the agency on this topic.
Yeah, that was the direction in which we were initially going, that we wanted to know the complete exposure of the patients, but then it was becoming difficult. So we felt that instead of waiting for another 20 years for information, let us go with the information which is available or easily available. So I remember it was in 2017 when I was sitting with my medical physics colleague in my hospital. I told him that when I have to get my CT scan, I don't go outside this hospital. So why can't we assume that the patient come to this hospital for all their services, and let us find out that. And that is what we did. So we have data on the CT part. We are now working on the nuclear medicine part, the PET CT. We have data also from the interventional procedures. At our hospital, we had 7-8 years data analyzed, and we found that 4% of the patients undergoing interventional radiology had more than 100 millisieverts. So we are working on the data for similar for nuclear medicine, the PET CT and all that. And outside the hospital and outside the health service under which the patient has undergone is another thing. So all these things, we encourage all of you to get involved in your own hospitals, in your own country, and generate more data. So that will be helpful.
Thank you. There are more questions coming. Maybe we can answer the question on availability. Do you know about availability of referral guidelines or clinical guidance on this topic? In fact, this was extensively discussed in the last technical meeting. the need of more guidance, but Madan, you can comment on this.
Yes, in the paper in which we studied the appropriateness, we have pointed out that the authorities dealing with the appropriateness criteria, they should develop the guidelines whenever recurrent imaging is involved. So there is a need to develop guidelines for recurrent imaging. If the patient needs many imaging, so there should be guideline how justification guidelines for that also.
Okay, how safe is the patient receiving more than 100 millisievert from a single exposure? I think the purpose of this webinar is not to create fear, so Madan, maybe you can highlight again or respond to this.
Yeah, as I said, that the purpose of the webinar is to push actions for safety. For example, if one asks me what is the single most important point which I will like to convey from all these studies which we have done and which others have done, I will say that the CT manufacturers should bring new systems which can do the CT at much lesser dose. And that is what we have reviewed, and we have also published. Is it possible to kill the radiation risk issue in CT? So we have published a paper on that. So the purpose of all this action is to improve the safety of patients, so that 5 years from now, if we have a webinar like this, we should be able to say that, oh, now our patients are safer. They can undergo, as many exams they need for the clinical purpose, we are able to perform today, which we were not able to perform 5 years ago. So the purpose of this action is to find ourselves in 5 years or so with a situation when patient can undergo any exam the physician feels necessary.
Thank you. And there are two questions that are, in fact, related to what you just explained. One is on the artificial intelligence and its impact on the doses, and also on photon counting detector in CT. So these two are also discussed in the technical meeting by leading experts. But yeah, Madan, your opinion on this?
Yeah, as I briefly mentioned, that we have reviewed the various technologies, and I will again refer to the papers. I had published this paper with Mark Cashel-Rice from Munich, and he and his group have published other papers also in investigative radiology, and there are other people also who have been working on CT technology. So there is the opinion coming is that there is a lot of potential for further reduction in CT dose. And one of our colleague has developed a monochromatic X-ray source in which in the breast at the moment it has been shown 6 times or even 10 times reduction in dose. So there is possibility of huge reduction in dose possible, and making CT imaging and other imaging safer than what we have today.
Yeah, a colleague asked about availability of data from PET-CT exams. Another topic that requires further, I think.
Yeah, we have almost the data ready for sending for publication. Another maybe 1 month or so. So there are at least 3 centers in the technical meeting in IAEA also. The Japan also had presented, and some I think Italy also. So there are many centers working at the moment on the similar studies from PET-CT, and I think within few months there will be data available from there.
I see a question here that maybe it's important to stress again. The question refers to 100 millisievert as some kind of dose limit for the patient, what we should do not to go above this. We should stress again that there are not those limits for patients. And Madan, maybe you can highlight again what you already explained, why we use 100 millisievert.
Yeah, I fully agree with that. We should not allow that thinking to build up. But at the same time, we had to find some way to create impact. In the past, there have been studies saying that so many % of the patients had dosed more than 20, another more than 30, more than 50, more than 100, more than 150. So that dilutes the emphasis. So the purpose of taking one single figure creates the impact. So once we have the impact, we need to do side by side and simultaneously, in fact, to create impression on that this is the limit. Yes, we need to do that, and everybody needs to do that. Yeah.
Yes, thank you. I see there are physicists in this in the audience because their questions related to the methodology used to estimate effective dose. Another important question, although we are not looking so much into the high accuracy here, but we should, of course, take into account the accuracy of those estimates. And there are different approaches for this. So maybe, Madan, in your studies, what methodology you use to estimate effective dose?
Yeah, this is a something which definitely requires prompt attention, because at the moment the dose management systems from different vendors are having different methods of estimation, and there needs to be the vetting of the accuracy by some organization. I mean, I would imagine almost 30–40% variation could be easily found. And also ICRP is preferring that the reference phantom of ICRP publication 110 should be used, so that once everybody estimates to the reference phantom, then one can compare. So there are actions ongoing. So this is one of the point which has been identified in all of our publication to act upon. And yeah, we need to work, and everybody needs to work on that.
Yeah, even more, there are different approaches using virtual phantoms adapted to the patient body size that allows for calculation of patient-specific organ dose, and from these estimate patient-specific effective dose. So there are directions of future research, and both are important, the methodology and how we use this information, because it's important that when we communicate those information, especially to non-specialists, to non-physicists or non-radiologists, to properly provide information how to use this and what this means, not to just provide numbers. And this should not be used by people without good understanding on the radiation risk. There was a question on how we can estimate radiation risk from this data, from this recurrent, from the cumulative dose data.
I think the papers on estimating radiation risk have been huge in the previous years, from almost 2002 or 3 to 2010. So there have been large number of papers in that direction. So we did not want to get into that. So we wanted to keep up to the dose, in fact. So, but one can do all those things which have been done in the last decade.
Thank you. I think I see a few more questions, but we are 10 minutes over the time. So the slide displayed now shows the link to the page on recurrent imaging in the RPOP website. And if you scroll down this page, you'll find the link to the summary of the technical meetings from 2019 and 2020. And because 2020 meeting was virtual, you can find, when you open the summary, you can find within the summary links to the recording of all the sessions. There were tens of very, very good presentations on different topics in that meeting, so you can learn more from those as well. There was a question to provide a list of publications that were used in this webinar. So maybe we can think about Madan creating some kind of bibliography after the meeting and sharing with the meeting participants, with the webinar attendees. Do you want to add something at this point? I think we.
I think we are already much behind time. I think I will like to thank you and IAEA, your colleagues who have helped to make this webinar happen. On our side, I will like to thank IOMP Executive Committee and IOMP school colleagues to have supported this joint collaboration. And I will like to thank all the participants for their really enlarged presence, and those who asked questions and participated in the poll that helped us to understand the things better. It is not usual to have such large attendance and to be able to get their feedback. So even if it took time, that was helpful. We could get your feedback, and after we finish, we will be able to have access to that feedback that will be educative for us. Thank you for providing that feedback through the poll. And thank you, all of you. And thank you again to the organizers and to Jenia in particular. Thank you so much. And I'm really grateful for the opportunity. Thank you.
Thank you, Dr. Rehani. Thank you. And thank our appreciation to the IOMP for this great collaboration. I want to invite the participants to register for our next webinar in 10 days. It will be a kind of continuation of the topic. We are going to discuss recurrent imaging again, but in the context of dental radiology with Professor Sarah Batut. She is head of radiobiology department of the Belgium Nuclear Research Center. This webinar will be organized in collaboration with the International Association of Dental Maxillofacial Radiology. This will be the first of the series of few webinars we are planning jointly with this organization, and also to inform you about 2 new e-learning courses just launched by the IAEA on radiation protection in dental radiology for dentists and other health professionals in the dentistry. And the second with video tutorials for on interventional radiology. I don't know why I cannot move the slides now. But you can find both of them on the radiation protection of patient training page, learning page. With this, I want to invite you to register also for the webinar newsletter, for the RPOP newsletter, to thank you all attendees, all participants, and to wish you a wonderful day or night. And you may now disconnect. Goodbye.
Bye.